Thank you all for joining us today. This event is organized in association with the 2020 High-Level Political Forum on Sustainable Development of the United Nations. This is the Sustainable Development Goals, and I'm reading right now, but the SDGs are the world's shared plan to end extreme poverty, reduce inequality, and protect the planet by 2030. They were adopted by 193 countries in 2015, emerging from the most inclusive and comprehensive negotiations in US history. They've inspired people from across sectors, geographies, and cultures. Achieving the goals by 2030 will require heroic and imaginative effort, determination to learn about what works, and agility to adapt to new information and changing trends. That's a description from the United Nations Foundation. Now, our area, drug policy, is one that impacts on many different areas of world activity and policy. The drug war affects health. It affects bad drug policies drive the spread of HIV/AIDS. It's a driver of inequalities, sometimes of instabilities in global security, and far too often impacts on human rights. So we are going to discuss a few issues that impact on, in which drug policy is impacting on the Sustainable Development Goals today, and all of them in the context of the COVID-19 pandemic, which of course has affected everything. We are going to figuratively and literally travel around the world today. Our first speaker will be Charles King, the CEO of Housing Works in New York City, who will give us a view of how the pandemic is affecting HIV/AIDS and other harm reduction efforts on the ground in New York. We will then hear from Nainan Vargas, and I hope I pronounced your full name correctly, Nainan, but you'll correct me if not, who is the Director AI of the UNAIDS New York office, and I think we'll be getting a global overview of the HIV/AIDS situation at this time. We'll hear from Dr. Ehab Salah, I believe Vienna-based, who's an advisor on prisons and HIV and the UNAIDS focal point for the UN Office on Drugs and Crime. Then we'll continue traveling east to the Philippines, where we'll hear from writer, public intellectual, Gang Badoy, Capati, and I'll say a little more about every speaker when they start. And then from there, then we'll move to our final speaker, Ruben Carranza, who is from the Philippines, but now we'll go back to New York, where he plays an important role at the International Center for Transitional Justice. So thank you all for joining me. Oh, I also wanted to say that, mention, as people probably assumed or saw, this is being recorded. So if if you're an attendee and you would rather not be on the video, then some options are to to disable the video on your end, and you have the option of changing your name as well. Conversely, if you're happy to be seen, feel welcome to enable your video and contribute to a feeling of togetherness for the event during this separated time. With that, I would like to introduce Charles King. And Charles has about 20, 25 minutes more that he can be with us. So After his talk, we will do Q&A um, with Charles. Um, Charles King is co-founder and the longtime CEO of Housing Works, Inc., a community-based not-for-profit organization that provides a full range of services, including housing, healthcare, mental health, chemical dependency services, legal advocacy, and job training and employment for homeless men, women, and children living with HIV/AIDS and other chronic conditions. Charles served on the governing body of UNAIDS as a member of the NGO to the PCB, I believe that's the Program Coordinating Board, and was co-chair of the New York State End of AIDS Task Force. He is currently the co-chair of the Ending the Epidemic Subcommittee of the New York State AIDS Advisory Council. He also co-chairs Act Now End AIDS, a national coalition towards ending the epidemic, and co-chairs the Visioning Committee of the National AIDS Housing Coalition. Charles holds both a law degree and a master's degree from Yale University and is an ordained Baptist minister. Charles, thank you for joining us.
Thank you, David, for inviting me. I've been asked to give an overview of the good, bad, and ugly for people who use drugs in New York City and New York State during the COVID pandemic. Just to set the stage, New York was the first metropolitan area in the United States to have a major surge of COVID. We were getting diagnoses well over 1,000 a day. Ultimately, over 20,000 people died. Our hospitals were overwhelmed. In New York City and much of the state, we went into a complete shutdown beginning the last, or the American version of a complete shutdown, I should say, beginning the last week in March, and that continued in New York City through May. And we have slowly been opening up the city, going at a far slower pace than many of the other states in the United States and metropolitan areas. So first, let me tell you what we don't know, and that is we don't know the data on drug overdoses during the surge, the pandemic. Data just isn't available. We still don't have data on overdose in New York City and New York State for 2019, much less the last 3 months. So it will probably be a year or more before we're able to really deeply analyze what has taken place. What we do know is that overdoses anecdotally are spiking at huge rates outside of New York City. Spiking not as high, but still spiking within the city over the last 3 months. Even then, we're not sure that when we get the data, we'll get the full measure of overdose deaths because they might well have been misclassified. If the decedent's death was recorded as COVID, this is particularly possible in cases where persons died in their homes alone. Our medical examiner's office during the peak, April and May, was not able to properly track, much less conduct autopsies on deaths during this time. What we do know factually is that coordination of an emergency response for people using drugs has been sorely lacking. We also know that emergency room visits for overdose in New York City went down dramatically during the second half of March and April, but by May had gone back up to normal levels. Possible reasons may include a lack of transportation. Ambulances simply were not available for hours on end during the peak of the surge, and emergency rooms were turning patients away before they even showed up at the door. And so we don't know exactly how this impacted, but we know that there was a tremendous decrease in people showing up at ERs in the midst of overdose. In the rest of the state, even though emergency room visits for non-COVID related events went down dramatically, the percentage of people showing up for overdose in emergency rooms actually increased proportionately. So that is a major indicator of the rest of state surge. Just to talk a little bit about some of the dynamics that took place in New York City, at least one major syringe exchange and naloxone distribution program in Upper Manhattan and the Bronx closed for over a month, leaving severe shortages in those parts of the city of both naloxone and syringes. Anecdotally, people who were enrolled in that program, instead of finding other programs outside of their neighborhood, ended up sharing syringes during the period that the program was closed. We also know that methadone clinic attendance declined precipitously as people on methadone feared going to their programs, worried about contracting COVID. There was an uptake in 7-day and 14-day distribution of methadone, though some programs were reluctant to increase take-home amounts despite the relaxation of restrictions on the federal level. Our New York City Department of Health started a home methadone delivery program, but even today it is grossly underutilized because many of the methadone programs are reluctant to trust their participants. That's both trusting them around diversion and trusting them if they get multiple doses not to overdose. So anecdotally, many methadone users have returned to other substances. Also, anecdotally, people in abstinence have relapsed at high levels due to social isolation, and this seems to account for many of the upstate overdoses that we've seen. One of the things that happened during the surge is that drug supply became highly unstable. Partly this was due to the difficulty of moving drugs when so many things were shut down, and also due to sellers becoming ill due to COVID. People who use drugs also suffered intermittent withdrawal due to lack of cash. As the city shut down, there were reduced opportunities for panhandling and other forms of income generation that people who use drugs in New York would frequently fall back on. Anecdotally, heroin without fentanyl actually became more common in New York City, leading to a greater use of stimulants with fentanyl. Still, there is a prevalence of heroin with high fentanyl levels in this very unstable and inconsistent drug supply. In both New York and Buffalo, anecdotally, nearly half of the overdoses have been due to fentanyl mixed with cocaine. And in May, in the state's capital region, in 24 hours, in a small town outside of Albany, there were 30 overdoses with 4 deaths due to crack with fentanyl. Methamphetamine use has been exacerbated as well upstate, often due to the lack of supply of other drugs. And there has been a dramatic increase in sharing syringes, particularly in rural regions of the state, which already have very high prevalence of hepatitis C. One bright spot has been that buprenorphine initiation through telehealth was a major breakthrough. And in addition to that, what we saw was various areas of the state, including Plattsburgh, for the first time developing strong buprenorphine programs. Anecdotally, we also can report a much better show rate for people on buprenorphine because of telehealth. So this is a major advance that we hope to hang on to afterwards. Always not right on the bupe front. So for example, in Buffalo, a number of people were arrested for bupe possession. 2 other areas that I would like to cover briefly, trying to stay within my time limit, are incarceration and homelessness. While our City Department of Corrections has not issued reliable data, What we do know is that there have been a much higher rate of COVID infection and a higher rate of death on our city, our largest city prison on Rikers Island and other local jails around the state than in the general population. This is really important given the high percentage of people incarcerated for drug-related offenses or for petty crimes associated with drug use. Here in New York City, a number of older and chronically ill inmates have been moved out of Rikers Island into hotels, but infection rates on the island remain very high, and access to PPE, including masks and gloves, is prohibited in all of the state's jail settings, leaving people very much exposed and unprotected. And at least one major county jail stopped doing buprenorphine induction during the COVID crisis, a serious setback as we've been trying to expand this. For homeless people, there have been a number of issues. Initially, our department, first of all, I should say New York City runs the largest homeless shelter program in the world, I believe, and that's because under our state constitution, people have a right to shelter. So on any given night, we have 70 to 80,000 people in shelter. Of these, about 13 to 15,000 are single adults. Generally, these are mass warehouses where people are living in a dozen to 1,000 people in a single room. Obviously, not the best place to shelter in place from something transmissible as COVID. The initial policies in the shelter system, particularly in the single shelter system, was that if somebody was suspected or tested positive for COVID, they were to be discharged from the shelter with no place to go and not allowed to return until they had a COVID negative test. With some powerful advocacy, we were able to stand up 5, and now there are 4 isolation shelters for homeless people who are positive for COVID or have COVID symptoms. And Housing Works operates one of them and is providing all of medical and behavioral health services in all of the others. In addition, we had a major crisis for people who are homeless living on the streets. Many of them refused to go into the shelter system. They were wary of the shelter system in advance, but were even more wary of the shelter system in light of the possibility of contracting COVID. And by the way, even now, when New York City testing is showing only a 1% positivity rate, in the shelter system, testing is showing a 7% positivity rate. So their fears were well-founded. This became a crisis when the city and state decided to close our subways from 1 o'clock in the morning to 5 o'clock in the morning and tried to round up homeless people who were living on the subways and coerce them into the shelters. Again, due to advocacy, the city is now standing up stabilization shelters in hotels, allowing operators to provide homeless people from the streets with a private room. And due to some incredible advocacy, we've had a major breakthrough in that our Department of Homeless Services is now requiring that these stabilization shelters operate on harm reduction policy. Contrary to that, in our test and trace program operated by the New York City Health and Hospitals Corporation, their isolation and quarantine shelters search people, and possession of drugs or alcohol is grounds for immediate discharge, even if you are contagious with COVID. Similarly, leaving an isolation hotel for anything other than a medical appointment is grounds for discharge. And of course, many people who are using drugs, who are dependent on drugs or alcohol, who can't bring it on site with them, would lead to procure, and thus we're putting people who have the possibility of transmitting the virus out on the street. Fortunately, I guess on that last front, very few people have been willing to go into these isolation shelters because of these rules, but still a lot of work to be done. I think I went over my time, so I will stop there.
Thank you, Charles. I will start with one question in the chat from Charlie Sullivan. the Citizens United for the Rehabilitation of Errants. But also, in case you didn't see it on the chat, I'll mention if you'd like to ask Charles a question or make a comment, request you go to use the raise hand function in the participant screen, and then I can call on people in turn. If for some reason you're not able to find that or it doesn't work, then people go ahead and unmute yourselves to speak. So the question from Charlie is, would supervised injection sites have reduced these overdoses?
That's a softball, no doubt about it. Certainly what we saw at the syringe exchange programs that remained open around the state was no reduction whatsoever in utilization of the syringe exchange services. And I want to compliment both the city and state departments of health with ensuring that these programs could remain open and do so safely. However, people were still having to go out and procure in a very unstable situation where they didn't know what they were purchasing. And so undoubtedly being able to inject or use where you're being monitored would have gone a long way to mitigate against overdoses. I would also point out that because of the shutdown and isolation orders, many more people were injecting alone by themselves, which of course is contrary to best practice to reduce the possibility of an overdose death.
I'll ask a follow-up to that. Just what is the status of supervised injection site efforts in New York?
So we had been very optimistic 2 years ago that we were going to get a research pilot authorized. We had the sign-on of the state health commissioner, who is the person who has the legal authority to authorize this. We had funding lined up. We had the support of New York City Mayor, the New York City Council, and the Ithaca Mayor. Unfortunately, after the U.S. Attorney intervened in the Philadelphia case, our governor got cold feet, and we've seen zero momentum on that. We had hoped that a new all-Democratic Senate would pick up the issue. They didn't do a study, but ended up not advancing a bill last year. We're going to take another run at the legislature this year.
Okay, thanks. Scott Cecil. Scott, you're next.
Yeah, thank you, Dave. Thanks so much for the presentation, Mr. King. I wanted to ask about the isolation shelters for people who are experiencing homelessness. So you mentioned, of course, the problem is that folks were being kicked out of the other shelters that were available. I'm wondering how testing fits in, because something stood out in there for me in what you said, which was that folks who either have COVID-19 or have symptoms could go to the isolation shelter. So how did testing fit into that, if at all? Because someone could be sick with another illness, right, and simply have COVID symptoms and then go to the COVID shelter and contract it. Were you able to include testing either at the original shelters that were kicking people out or at the isolation shelters, or both, or neither?
So just remember, or you may not be aware of this, but beginning the third week in March, due to the shortage of testing, New York City stopped offering testing to anyone who was not being admitted to the hospital. Therefore, we couldn't test. We could only go on symptoms unless somebody went to the emergency room. We did receive in the isolation shelters a number of people who were being discharged from the hospital, but we also took people in who were simply showing symptoms in the shelter system. Without testing them. And we were initially keeping people 7 days, then that increased to 14 days. It has since gone up to 17 days. Now we have the ability to test, and DHS has contracted with an entity to test all of their shelter residents. So we are able to do that. But the other thing I can tell you is we were seeing a lot of people coming in with very serious comorbid conditions. Fortunately, Housing Works had insisted on a rich medical staff for ours. And so we've been able to treat those other conditions, including diabetes, hypertension, OCPD. And it's actually because of that that we were asked to provide the medical care in the other 3 COVID isolation shelters, which we will continue to do. What we're seeing coming in now is largely people who are testing positive but are asymptomatic.
Okay, Ninan, you had your hand up.
Yeah, David, and thanks, Charles. I was waiting if there was somebody else who wanted to ask a question, but Charles, just on the you mentioned the harm reduction and methadone users and the provision of methadone to the doorsteps of people, and just correct me if I'm wrong. So we are looking, I mean, COVID has given us the opportunity to do a lot of innovative stuff. So, and as in HIV, we are trying to do multi-month dispensing. So is this something that you think will come out of this, the way that we're functioning during the COVID, that we'll be able to give multi-day doses as a policy shift across the programs in New York State and maybe other states as well? Thanks.
I am more comfortable with saying that we will be able to hold on to our advances with buprenorphine. Then I would say that we will be able to hold on to our advances with methadone. And I think the problem there is that buprenorphine prescribers are far more willing to experiment. They're also far more willing to trust the people who they're prescribing for. I think in the methadone clinics, it's an old model. There's a lot of very traditional operators, and the presumption there is that you don't trust the people you're prescribing to, both for purposes of diversion as well as to avoid overdose. So while we have seen a fair amount of 7 and 14-day visits, many of the programs are still insisting at the end of 7 or 14 days that people come in for toxicology, which sort of defeats the purpose of home delivery, though they are getting extended supply. But then all too many people, programs are still adamant, especially new initiates, that they have to come in every single day. And that has been an uphill battle to persuade programs to trust the people who are there. They're there because they want treatment. Can we show a little bit of faith? But I'm not as optimistic with methadone as I am about buprenorphine.
Ninan, you may as well have left your microphone on because you are next. Well, first, sorry, any further questions for Charles or comments? Okay, well, Charles, thank you for taking time on sounds like a busy day full of errands to join us here.
Thank you. It's good to see you all, and I apologize for needing to leave early. Take care.
Actually, if you're still there, we just had a question come in on the chat. Well, I'm sorry, Charles. Charles did sign off. So Ricky, I will be sure that Charles gets that question, and we'll send you the answer. If anyone else happens to know, Ricky Avancenia of the Ecological Society of the Philippines has asked, did the 78,000 nightly who are in shelters in New York increase or decrease during the lockdown? Okay, so Ninan Varugis, is that if I pronounced your name correctly? Okay, good.
Varghese.
Ninen is the Director AI of the UNAIDS New York office. He has been with UNAIDS for over 17 years and has previously worked with the World Health Organization in Geneva, Switzerland. Ninen has been involved with the response to AIDS from the late 1980s. He has over 33 years of experience at the country, regional, and global level. Of these, more than 28 have been in the field of health and development, including HIV/AIDS, malaria, tuberculosis, sexual and reproductive health, and social marketing. Before moving to the development sector, Ninen worked for many years in the advertising industry. The UNAIDS office in New York works at the political level to help unite the world in responding to HIV and AIDS, accelerating progress around the Sustainable Development Goals, and to ending AIDS as a global public health threat by 2030. Over the last 6 years, Ninen has been an active proponent on drug policy and its impact on the HIV epidemic. So thank you so much for joining us today, Ninen.
Thank you so much, David, for that kind introduction. And also, just want to put on record our thanks to DRC Net Foundation and you for organizing this during this very hectic HLPF virtual meetings. But thank you all for joining as well, and thanks to Charles for his introductory discussions. I just want to give as David mentioned, an overview of the HIV situation globally. As you know, the International AIDS Conference is ongoing in San Francisco and Oakland, and UNAIDS just launched its global report on the 6th of July, called Seizing the Moment, Tackling Entrenched Inequalities to End Epidemics. And it was launched by our Executive Director, USG, Vinny Banyina, as you know. The report talks about some key issues. It says that the AIDS pandemic remains a global crisis fueled by inequalities. There have been great successes in HIV response, but progress is extremely uneven. Because of persistent inequalities, we will miss the 2020 targets. We must double down and act with greater urgency to reach millions still left behind. We also see that gender inequality is denying women and girls the ability to make their own healthcare choices. And then, of course, COVID-19 has seriously impacted the AIDS response. Even before COVID-19, we were not on track to meet the global targets for 2020. Now that COVID-19 crisis is blowing us way off course, but community resilience and innovation has shown the way in mitigating the impact of COVID on HIV. As you know, the 2016 high-level meeting and the political declaration contains programmatic, epidemiological, and financial targets for 2020. 2020 has come, but we are missing a lot of these targets on all financing, programmatic, and epidemiological impact. 3.5 million additional new HIV infections because of not reaching the fast track targets. 820,000 additional AIDS-related deaths because of that. Women and girls continue to suffer and be at the forefront of the epidemic. And unequal gender power dynamics, harmful gender norms, and masculinities and violence against women and girls continue. Despite impressive gains in access to treatment, AIDS still remains a leading cause of death among women 15 years and older. Adolescent girls, young women account for 1 in 4 infections. About 4,500 adolescent girls and young women between age 15 and 24 become infected with HIV every week, and that's unacceptable. Moving on to COVID. As countries grapple with growing COVID-19 pandemic, the leadership, resources, and infrastructure of HIV responses are being mobilized to meet the challenges. So we are leveraging HIV leadership and lessons against this new pandemic. National directors of AIDS programs and coordinators are leading COVID-19 responses in about a dozen countries. The Global Fund and World Bank have made funding available. the IAS is also doing special webinars. Local, national, and regional international HIV community organizations are bringing their energy and experience to the COVID-19 response. As the coronavirus spreads in countries in sub-Saharan Africa with high HIV prevalence, there is evidence that people living with HIV and people with active tuberculosis are both at higher risk of COVID-related morbidity and mortality. People living with HIV and people at great higher risk of HIV infection are also facing life-threatening disruptions to health and HIV services as COVID-19 cases overwhelm health system capabilities and capacities and lockdown limit movement and strain economies. Voluntary medical male circumcision, condom production and distribution, PrEP, HIV testing and treatment, and other programs have all been negatively affected. Efforts, we've seen that COVID-19 is amplifying inequalities. Efforts aimed at controlling COVID-19 have penalized the most vulnerable in society, such as women, the homeless, those living in poverty, or those who are already marginalized, stigmatized. There's been increase in domestic violence, vulnerabilities related to children being out of school, COVID-19 restrictions and police powers used to harass, harm, and arrest sex workers, LGBTI, and other marginalized and criminalized groups. Uses of criminal law to sanction COVID-19 exposure and transmission of COVID-19 are a reminder of the stigma and discrimination that people living with HIV have been facing for decades. We have seen that if services to prevent mother-to-child HIV transmission and was similarly halted for 6 months, there would be increases in new children's infections and mothers across many countries of the world. I just want to come back and touch some issues related to specifically to drug policy. More than 12% of the estimated 2 million people who inject drugs globally were living with HIV. And of course, the latest UNAIDS estimate suggests that people who inject drugs in 2019 had a risk of acquiring HIV that was 29 times higher, greater than a person who did not inject. One of the really worrying finds that we have in our new report is that a majority, 62% of new adult infections globally in 2019 were among key populations and their sexual partners. These populations include workers, people who inject drugs, that's about 10%, prisoners, transgender people, and gay men and other men who have sex with men, constitute small proportions of the general population, but they are at an elevated risk of acquiring HIV infection, in part due to discrimination and social exclusion. Also, there are significant gaps in HIV testing among key populations at high risk of HIV infection, meaning that 1/3 did not know their HIV status. This testing gap is even higher and larger for people who inject drugs. Drug use or consumption, as you know, and possession of drugs for personal use is specified as a criminal offense in 111 of the 134 countries with available data, with only 17 countries reporting that possession of a certain amount of drug is allowed by law. This meeting that you have convened is very timely because a repressive enforcement of drug laws, including harsh criminal penalties and the registration of convicted drug users, force people who use drugs away from public health service into a hidden environment, increasing their risk-taking behavior and heightening the chance of acquiring or transmitting HIV. Women who use drugs continue to face major challenges in accessing sexual and reproductive health services, and the human rights-based, public health-focused and gender-responsive HIV prevention and care that they urgently need. Rates of intimate partner violence and gender-based violence among women who inject drugs are up to 5 times higher than they are among women who do not use drugs. Discriminatory laws, policies, and practices, and multiple intersecting forms of violence, stigma, and discrimination, including those related to accessing health, education, employment, and social and legal protection services, or when interacting with law enforcement, are among the barriers that have a significant negative impact on their access to healthcare. And as I mentioned before, there have been alarming reports of use of police force and powers to harass, harm, and arrest vulnerable and criminalized groups such as sex workers, people who use drugs, and people living with HIV and LGBTI people. I just want to end by saying that as international discussions and commitments to accelerate research and development of COVID-19 vaccines got underway, UNAIDS has co-initiated the mobilization of a movement for a people's vaccine with a group of over 150 world leaders and experts led by South African President Cyril Ramaphosa and backed by civil society, academic experts, thought leaders, and philanthropic organizations, united in an open letter calling on all governments and other actors to ensure that any quality assured vaccines, treatments, and tests for COVID-19 be free of exclusive rights, produced at sufficient scale, distributed equitably, and made available to all people in all countries free of charge. And I just want to throw in a plug here, David, if you agree. Tomorrow at the HLPF discussions at 10:30, our executive director will be addressing issues on inequality and leaving no one behind at the HLPF main thematic section. I want to end there. Thank you, David.
What's the best website for to go to for that?
So all our reports are available on the unaids.org website. All the data that I mentioned is available. There are slides available that you can use. Everything is on our website. So please go ahead and have a look there, please. Thank you.
I mean, is that a 10:30 session tomorrow with your executive director being broadcast publicly?
Yes, it's being webcast.
Okay. Webtv.un.org.
That is correct.
Okay. So I was mistaken earlier when I thought Dr. Salah had joined us, but he is here now. Ehab Salah is advisor on prisons and HIV, as well as the UNAIDS focal point for the UN Office on Drugs and Crime. He's a medical doctor specializing in medical epidemiology and public health, with more than 20 years of hands-on experience in communicable disease research, prevention, and control. Prior to joining the HIV/AIDS section in UNODC Vienna in 2014, he coordinated UNODC's HIV in prisons program in different geographical regions since 2006. Dr. Salah, would you like to speak on this time, or given that you've just signed on, would you rather speak after one or two of the remaining speakers?
Hi, David. Hi, everyone. Yeah, I can speak now if you allow me. So, so first, thank you very much for giving me the chance to present in this important side event. And I'm glad to be with you today. I don't know how much time do I have?
Up to 10 minutes.
10 minutes is fine. I'll try to wrap up my presentation on time. And let me introduce myself quickly. My name is Ehab, and I work for the United Nations Office on Drugs and Crime. I'm coordinating the UNODC work on HIV in prison settings. I've been requested to share with you some data, information about the current situation and service coverage related to HIV and other infectious diseases in prison settings. Again, so let me start with the situation in prison settings and where we are and what are the vulnerabilities of infectious diseases and people in prison settings. It's very clear that the majority of prisons all over the world are suffering from overcrowding, and in many countries, in prisons, there is overrepresentation of people, of key populations like people who use drugs, people who inject drugs, sex workers, men having sex with men. Just all of them, because of the punitive laws, are overrepresented in prison settings. And prisons is not separated from the community. All modes of transmission are there, including through injecting drug use, contaminated injection equipment, as well as sexual contacts as well. In many countries, the health profile of people in prison is lower than the community. This is where they're coming from. This is coupled with the low access to evidence-based and human rights evidence interventions for HIV, TB prevention, treatment, and care. Also, the situation, the current situation, living condition and working condition in prison is not at the same standard as in the community, not speaking about the high level of stigma and discrimination that's associated with people in prison, people who use drugs in prison, people living with HIV in prison, and of course, genders in many countries. One of the major things that hit us very hard, especially during the COVID-19, is the prison health system is being isolated from the public health system. And this has been noticed in many countries during the pandemic of COVID-19 in many countries, where many countries found itself isolated from the public health system. This means that they don't get enough resources, including testing and treatment. We are talking about a total population of 10.7 million people in prison at any given day. 10.74 million people, according to the latest release from the International Center for Prison Studies. 10.7 million, and of them we have like 7% women. So the latest report indicating that there at any given day is around 714 women in prison at any given day. What about the situation of infectious diseases? According to the latest report came from the UNAIDS global monitoring, as well as some global burden studies released in 2016 in the Lancet. It says that HIV in prison is 4.7%. This is the average prevalence of HIV in prison, 4.6%. And this makes people in prisons like 7 times higher than the community. When it comes to hepatitis C virus, the prevalence is 15%, 4.8% for chronic hepatitis B virus, while 2.7% of people in prison are suffering from active tuberculosis as well. COVID-19, we're still tracking some data, but we are not aware of what is the prevalence, what's the current situation. We're still learning and trying to create some platform where we can collect them some data on COVID-19. We're still working on this. However, most importantly, HIV and tuberculosis are still one of the major causes of death and mortality in prisons in many countries. Some data I want to share with you that UNODC, we released recently the Global Drug Report 2020 that has been released like a couple of weeks ago. And it has some data on drugs and people who use drugs in contact with the criminal justice system. The survey conducted in 2018 and its data presented in the World Drug Report indicated that in 1 year, there's 3.1 million people arrested because of drug-related offenses. 1.2% are related to trafficking, while 1.9% are because of the possession of drugs and the use of drugs. This is the data for 2018, and I would like to invite you to have a look at the World Drug Report where you can find more details about this. This 3.1 million people came in contact with the criminal justice system in 1 year. 1.6 of them were convicted. This means that, as we speak, if we talk about 10 million people in prison at any given day, the total number of people who are in prison because of drug-related offenses is 2.5 million people as we speak today. This is like 25%, and this percentage can go higher in other countries as well, in many countries. Speaking about the regional prevalence of HIV and TB in prison settings, you will see that there is a lot of regional diversity. So in some regions like East and Southern Africa, you will see the highest prevalence can reach up to 15% of the HIV prevalence among people in prisons. While in other regions, you will see that hepatitis B is really high, like in West and Central Africa, where the prevalence of HBV, hepatitis B virus, can reach up to 25%. Other regions, hepatitis C can be higher, like Asia Pacific and Eastern European Central Asia. This is where the diversity of the or the regional diversity of the prevalence of infectious diseases in closed settings. This is why UNODC and other UN agencies, including WHO, UNDP, and ILO, UNAIDS, of course, as a partner with us in all our initiatives, we came up with a comprehensive package of 15 key interventions where countries can adopt to deal with issues related to HIV and other infections in prisons. These 15 key interventions are focusing on the prevention of HIV, HCV, diagnosis and treatment, gender-responsive interventions, including sexual and reproductive health, prevention, diagnosis of tuberculosis, as well as occupational hazards, because when we talk about infectious diseases, we should not exclude people working in prison. So one of the interventions is related to the occupational safety for people working in prison settings. So this is the set of interventions. And what about the situation? What's the current situation? What are the service coverage? So UNOIDS commissioned a survey in 2018 to measure the coverage of these key interventions. I'll share with you some of the facts for your information, and some of them related to HIV prevention among people who use drugs. So the report indicated that, first, the report is covering 189 countries. And out of this number of countries, only 57 countries provide condoms for people in prison. Only 56 countries provide OST, or opioid substitution therapy, for people who use drugs in prison. At the time of this report in 2018, only 11 countries have needle and syringe program in prisons, and only 79 countries perform HIV testing, voluntary confidential HIV testing for people in prison, while 88 countries reported the availability of antiretroviral treatment in prison settings. This gives you an idea about the situation when it comes to the services available. We have a huge gap in service provision in prisons and other closed settings. For example, if we focus on OST, opioid substitution therapy, and needle and syringe program, you will find, as I said, that only 11 countries in the world implementing needles and syringe program in prison settings. What's the regional distribution? You will find that 5 out of the 11 are in Western Central Europe and North American countries, while in many regions, this service is not available at all. So in Western Europe, North American countries, many of the services provided there, while where the prevalence are high in other regions, it exists or it doesn't exist at all in many countries. This is the current situation, and this is why we are very much concerned about this. We're working with member states to ensure that people in prison have access to evidence-based and human rights interventions for HIV, TB, and other evidence-based interventions in prison settings. So what we are promoting is improving monitoring and evaluation of services, especially regarding to key population in prison settings, encourage the voluntary testing and treatment for people in prison, reducing overcrowding, and now we talk about COVID-19, and promote compliance with the Nelson Mandela rules. I'm sure you're aware of the United Nations standard minimum rules for the treatment of prisoners. These rules, also called the Nelson Mandela rules, it has been adopted by the United Nations General Assembly in December 2015. And within these rules, there is specific rules addressing the health of people in prison, saying or indicating that healthcare services in prison should be equivalent to those provided in prison, and also in emphasizing the importance of the continuity of care for people in contact with the criminal justice system. Our website, we have a lot of publications. You can look at it and you have to see it. But for a minute, if I have one more minute, I can talk about COVID-19. This is the topic of the hour. And COVID-19 and its virus, SARS-CoV-2, hit prisons very hard. And we have been faced with many, many issues related to prevention, preparedness, and control of COVID-19 in prison settings for so many reasons, including the overcrowding, where we talk about one of the major measures for the prevention of COVID-19 is physical distancing, which is not an option in many prisons all over the world because of the overcrowded prison. And this brings to us the long-standing call of the United Nations to reduce overcrowding and utilization of alternative to imprisonment for minor non-violent crime. And here I would like to mention that the United Nations General Assembly special session on drugs and the world problem of drugs, indicating or encouraging member states to utilize alternative to conviction or punishment for tiny or small non-violent crimes, including the use of drugs. I leave it there and back to you, David, if there's any questions I can respond to, if possible. Thank you very much.
Thank you. We do have some questions from the chat. I'll read, but a question from Eric Sterling, the longtime, now former president of the Criminal Justice Policy Foundation. Since about 1/4 of the world's prisoners are in the US, is your data on the imprisoned especially true of the US, or does HIV, tuberculosis, etc. in the US skew the global data? For the lack of health care and the prevalence of disease in prison, is the US near average or greater or lesser than the rest of the global average?
Okay, thank you very much for this question. The total number of people in prison, as I mentioned, including people in prisons in the US as well. And as I said before, this is the data that we got from the International Center for Prison Studies, and it has a release every couple of years about the current situation of people in prison. And you can go and visit yourself and get some more information about the number of people per country. It's available with the current situation of overcrowding and the staff and number of facilities and so many other data. You can get it from there. And regarding the average of the prevalence, I'm not sure about the average this. I might need to get back to the current situation right now. What I have shared is the global situation, which includes the data. It came from a literature review, also a questionnaire and survey that has been shared with all member states. But this average, I don't have an answer right now, but I need to get back to you, to David, and he can share the answer with you. I promise I can do that. Okay,
thank you. And thank you again very much for joining us. We do have a comment and question from Andrew Tatarski, who is very concerned about the likelihood that lethal overdose will rise during the pandemic. So this is a question for any speakers who have information on this, or anyone else, feel free to share in the chat or by speaking later. But what has been observed officially, and how might we anticipate and mitigate this looming crisis?
Thanks, David, and thanks for this important question. And I would like to share the same concern about the level of overdose mortality. Maybe I should have mentioned in my presentation that people in prison are at a high risk of the fatal drug overdose and the mortality related to drug overdose, especially upon release. And there's a study that has been released in 2010 between WHO and UNAIDS. It's indicating that people released from prison, they are at 40 times higher than the general population to suffer from mortality, high mortality related to drugs. This is why we always promote, part of our comprehensive package is the promotion of prevention and management of a drug-related overdose, especially upon release. This is very important. Yes, this is a very concern, and we promote this, and we encourage member states to adopt measures for overdose prevention and management, especially upon release. Most importantly is also, during the COVID-19, some countries started to release prisoners as one of the measures to reduce overcrowding. This is fine, and we are promoting the reducing of the overcrowding in prison, but we need to highlight two major issues. Number one is the linkages with community health care services. We cannot just simply release people without linking them to community health care services. Some data from countries indicating that these people, they lost the gains that has been conducted in prison. And the other thing, which is also very important, is to ensure that when people are released, we need to select specific categories to be released, and also to make sure that it's not compromising the public health and safety. Back to you, David.
Thank you. And I know that Dr. Tatarsky, who posed that question, posted a link to an article he published in Psychotherapy Networker on changing attitudes towards addiction treatment. And I'll be doing a summary of information like that later on. But everyone be sure to check
Okay.
before you sign off. So our next speaker is Gang Badoy Capati. And Gang, I will read your bio, but in the meanwhile, I'm enabling screen sharing for your presentation, so you can set that up. Gang Badoy Capati is a writer, public intellectual, and alternative educator, best known for founding RockEd Philippines, a multi-project creative collective guided by the UN Sustainable Development Goals. RockEd advocates civic education through rock and roll culture, mainly music and art performances and programs held with volunteer artists outside the classroom. She hosted the long-running weekly RockEd radio talk show at NU 107 and, following the station's closure, at Jam 88.3. Gang is a staunch advocate of volunteerism and is a prime organizer of disaster relief operations. She's also the director of Project Steady and is a Mindanao Peace Games advocate. Gang studied at the University of the Philippines, Diliman. In 2010, she was recognized as one of the outstanding women in the nation's service, towns, UWNS, and perhaps Gang will clarify, also received the 10 Outstanding Young Men Award that same year.
Isn't that awesome? Gender fluid. Yeah, I won the men's award too. They ran out of good men that year. So anyway, can everyone hear me? Good. You are all so serious. You know, it's past midnight where I am. So if I say anything illogical that doesn't make sense at all, if I say anything shitty, you will just let it pass because it's now 1 a.m. Okay, let me start. I run a project called Rock the Rehas. Rehas in Filipino means bars. So we've been teaching I was a teacher inside the maximum security prison for 9 years, 2007 until 2016. And the only reason why I'm no longer teaching in prison is because when President Duterte assumed office, I lost my permit. We lost our permit to teach for many reasons. And I was also, within his first 6 months, he had that Senator Laila de Lima case, and everything that the senator was accused of is about a drug trade inside prison, that particular compound where I teach. So President Duterte changed and shifted all the ways that they did security inside. He reassigned special action forces to guard the prison and etc. And then said that there is a large drug trade, and Senator De Lima is allegedly in the center of all that. So other than not renewing our permit to teach inside, I was also advised by my lawyers to stop teaching because it's so easy to get me into trouble in this era of a lot of fabricated things and fake news and etc. And given the fact that I've been doing my research and psychotherapy training inside the maximum security prison for 9 years, I definitely have a lot of pictures inside, and I think that's one of the evidence. Those are the exhibits they showed in court, that this is the reason why Laila de Lima has a drug trade. Look, she has a picture inside, and I have too many of that. It's too easy, so they said, halt for a while. It's a little heartbreaking, and if you don't mind, I'm going to share some pictures since you all look very, very grim and very serious and very can I lighten you? No, I won't lighten you up a bit, but I'm going to have to share this, okay? So this is our project. As I say this, I'm going to run through pictures so you're not too bored. Okay? Okay, that's me.
Okay.
That's me, and this is my class. Okay, this is my first class in 2007. That's me. It's And this is my driver. He's always with me. He's Mang Estong. So this is I started first as a creative writing teacher inside. Definitely it expanded to art therapy, and we were able to build a library and an audiovisual center inside. This is it. Can you see it? Can you see my okay.
Yeah, I can see it.
I made sure that every time I had class, that everybody is required to shower before my class. And if they have, they weren't required to wear orange in the first 4 years. So I asked them to wear their best shirt. But then when a new commander came in, they said, no, you gotta wear orange forever. So that changed. But I should have had earlier pictures, but I have actually. So I would bring in friends who are saxophone players. I brought in a chef just to make crepes for everyone. And this is my friend. He's a musician. That's what better thing to bring into people who have not much freedom, but jazz, what better thing to make them experience. So I brought a live saxophone player, musician. He's kind of famous here. His name is Rastem. And then eventually we expanded to art. I figured I can only make them write so much. And then so eventually I said, let's try something new. And so it expanded. One of the breakthroughs of my class, of our class, I have a partner teacher, Lex. He teaches Saturdays. I teach on Wednesdays. And we did this for 9 years. I did the first 5 years, and then Lex joined me eventually. Thank God, because that kind of got a few of the weight off of me. So we expanded. And now I'm doing art therapy, and so I figured since I'm doing art therapy, I might as well study it. So I studied applied psych with it while I was teaching, and I was receiving great training. And I thought my art therapy certification is shit compared to the education I'm actually getting in prison. And there's a reason. I have a point. While I'm showing you this, because I need you to see what the Philippines is like and what kind of programs are here and why COVID is heartbreaking right now. This is a sample of a poem. Of course, you don't understand it. I don't care. I just wanted to show you. This is bunso. Okay, bunso in English is actually youngest child. So in Filipino, it means youngest child, and that's his name. And I said, why is your name bunso? And he said, because I was the youngest I was the youngest in death row. So I said, oh, okay. When you teach in prison, you learn a lot of great cheek muscle control because you can't react, and etc. I said, oh, okay, you're the youngest. So this is Bunso, and he's, I needed to show you him because on my birthday, he had a gift for me, and you need to see this. He tattooed my face and name on his thigh, okay, at the back.
Oh.
I know. Yes. So I need to share this because I need to show you how they're so human and so they're so lovely. They just weren't parented. So I said, oh my gosh, it's very strange to have your name tattooed on someone's leg. Okay. So I said, oh, why'd you have to do that in our language, of course? And he says, nothing. I just wanted to thank you because, all our teachers in the past would never come back. Like they'd come once or twice and they never come back. And he said, you've been with us for like 4 birthdays by now. And so I just wanted to thank you and tattoo your name on my leg. And I said, okay, thank you. And I said, didn't you want to just give me donuts? I mean, yeah, it's the same. But I think my lesson, the dark and deep lesson here is, this is how they say thank you. And this is how we're just going to have to say, you're welcome. Well, thank you. You're welcome. There's a different expansion of self that happens when you're around people deprived of liberty. Your heart really has to stretch. I mean, because really, if I stayed in my normal heart size, I'd say that is so creepy. That's my name and it's on your leg. But, and so that's the lesson I learned from one of the lessons I learned. Many. Now this guy, his name is Mike. Every year I spend more birthdays with the inmates more than my family. So this is one year that they gave me a cake, and this is Mike. And it's important that you remember his face. Look at his face, okay? Because Mike was released last year, And he was the one who delivered our hygiene kits yesterday. Isn't that awesome? Okay, this is Mike with all the hair in the world, and that's me. And I was so young there. And then today, this is Mike. He delivered our hygiene kits and all the soap that we delivered, and that's him, former inmate, now donating soap to his former guards. And he posted with them. They all love him. And they didn't recognize him at all because he had zero hair. And he used to have so much hair. So this is the guard that who remembered him and said, "Hey, weren't you here before? Weren't you an inmate?" And he's like, "Yes." And this is the soap we gave them. We're only allowed till the gate, of course. And when I looked and I said, "Bye," this is our first delivery yesterday, the day before last. I said, "They look really sad. I think I'm going to change tactics." So we decided to buy colorful masks. I decided to make it really, really colorful. And when we distribute, all of them will have masks in different colors. I thought that would help. This is the social distancing that's happening. And this is what they look like when we said bye. And this is what it looks like when they close the gate. That's me. Okay. Now, COVID. We're going to talk about COVID now because I only have 10 minutes, so I'm talking really fast. Recently, they said that there's an average, we have 28,000 inmates, persons deprived of liberty in the maximum security compound. The compound is the minimum, medium, and maximum. Okay, the capacity of the compound is 6,435. Can you believe that? 6,435, and we have 28,000 plus. That's about 330% over the capacity, right? So that in itself, with or without COVID, it's like it's swinging the gates of injustices right there. So in March, since we're focused on COVID, in March there was a recorded 60 deaths, and they weren't sure if it was COVID or not, right? So April 62, and so we finally private citizens actually finally asked and said, there's just so much death. Why don't you test? This is COVID, etc. And the spokesperson, his name is Gabriel Shaklag, said, "Oh, no. 60 is an average number of deaths really in prison because we have 28,000. So that's not COVID. Don't worry." But in May, remember, March 60, April 62. In May, 136. Okay, so they said, "Sir, last month you said it wasn't COVID, so why don't we test now because it doubled in less than a month?" And the same spokesperson says, "Oh, since the lockdown, they haven't had visitors and they've been very lonely. And when you're lonely, your immune system goes down, and this is possibly why there's more deaths this month because they were sad." That's a real quote, by the way. I can send you the link. And then I said, wow, that's really awesome. Of course, science has supported that. Definitely your immune system goes down when you're sad. Okay, I wasn't disputing that. I'm just saying might be better if we check. So recently, there's been more tests. But then I realized when coronavirus loomed into view, the entire world had very little answers, except for Dr. Salah has more answers than most of us. And if you have normal communities with very little space, that's not even in prison. Can you imagine what our prisons are like? And like Dr. Salah said, and the whole world says, one of the guaranteed things that you should do is actually physically distance. How? Where will they go? What, climb a tree? So there's none. So what have they done? Like you said, some were transferred to other facilities, and they prepared one space in the medium security that used to be storage, and it's now home to 132 senior citizens who are inmates, which brings up the question, why are they still inmates? If they're 80, they should be released when they're, I don't know, maybe 75. So there's so many other things. And the idea that COVID did not break any system or worsen the system, it really just truly revealed the cracks. It really, really just revealed the cracks in the system in high definition. So there's not much testing going on in or outside prison in the Philippines, so I don't have much to contribute there. So a lot of the deaths a lot of the spouses of inmates have been coming out in media saying, I don't even know where my husband is. They said he died. And when I ask them why, they say, consider pneumonia. That's actually what's written on the death certificate. Consider pneumonia, consider myocardial infarction, consider, there's this word consider because they're not sure. That's how it is. That's how it is in the Philippines. And this is just one facility because it's the only facility I can speak of. We were, I don't know the rest, but that's outside Manila, outside the capital. I'm not sure what the numbers are. I'm not sure exactly what's lacking, a system, consultation, or resources. Maybe all. So that's pretty much where I am. So I guess, like a really true, honest COVID-19 report on prisons, it's going to end at like in an unfinished sentence. So, any questions? I know I look happy doing this report. I really should practice my solemn face. But
Can you hear me?
Ruben's laughing. You know why? When Filipinos are terribly, terribly grieved, we laugh. Because
a coping mechanism.
Wailing is right beside laughing in our brains. And it's 1 a.m. I'd rather smile. But really, it's obviously a defense mechanism. But we are not numb to it. I am not. You are just strangers. That's why I'm not showing emotion. But I'm deeply saddened by what I see. In fact, this is how sad I am, and I'll end my presentation with this. We delivered. I wasn't allowed to go down from the car. I just waved, and then they dropped the boxes off, and I was too afraid to ask who among my students are still alive and who are dead. I didn't want to ask. I didn't want to know. And that's how I'll end my sharing. You may ask. You may ask any question.
Can you hear me? This is Michael from Delaware. Can you hear me?
Oh, I think so. Yeah. Hi, Michael.
Oh, I'm new to Zoom, so if I push the wrong button, forgive me. I liked your presentation.
Oh, I think thank you. I wish you should have better statistics.
Oh, I love the slideshow.
Oh, I didn't. I wish our slides. I wish my slideshow showed them free, COVID
That's
free.
great. I used to teach English and creative writing, so I know all the exciting energy you give out and the exciting energy you get back. It's a beautiful thing.
And it's so gosh, may I use the word healing, or is that too naive? I think it's really healing because 80%. I'm making that up. I don't know. Majority of my students are very excited to read their work. When I ask them to read their work, like who wants to read their work, are like grown men, me, mom, me, and they're all like bearded and tattooed and triple homiciders and etc. And they want to read poetry. Okay, so they read poetry, and I'm thinking, why are they? I really thought nobody would participate, but it turns out, and I realized this after years, these are the children who never had parents, who put their drawings on refrigerators. These are men who grew up, who never had a schedule, and now that they're in prison, they're actually feeling like a little more organized. Like, at least now I know what to do at 8 a.m. A lot of them have been street kids, been in crime from the time they were toddlers, no parents anywhere, or if there were, it's probably better if they didn't. So and this is real, and I think the reason why I'm sharing this is because I am very sure, I am 100% sure everything I said you all know. Everything I said you have all seen and imagined. Everything I know, everything I said and shared, even the grief, but maybe not the tattoo of my name. Everything I shared, you already know. The reason why I shared it is because I don't want any of you to be numb yet. I know you've been doing work. You're constantly exposed to large pain, gashes, collective inhumanity and injustice, but we forget. I think sometimes we forget. So I think I wanted to remind all of you. It's the only reason why I said yes to speaking after midnight, because I think these people have reach, have heart. But maybe sometimes in order to survive our work, we need to be numb. I get it. But maybe every now and then we should take down the anesthetic and actually really feel it. And then maybe a different action will happen when you allow
Mhm.
yourself to feel something again. Is that okay? Is it okay to
Yeah, I have one last question. I think there's someone
Sure.
after me. So what do you do with their writing? Do you put it on a blog or print it
Oh,
out or make a little notebook?
well, we had. Oh, I'm so glad you asked because I'm so proud of this. I took a picture of a lot of their poetry, like I showed you earlier. I think there's one handwritten, and we projected it against the wall of a museum all day, all their
Mhm.
work. You can see the large handwriting, and it was an exhibit. It's like my exhibit. That's one. Second, have all the papers still with me. I do intend to scan and turn it into a book, but I want it as is. So you see their handwriting because it's so funny. I don't have materials all the time, so sometimes some of their poems are written in the inner foil of a cigarette pack or whatever paper we had. So it was really interesting.
Oh, yeah, it
Yes,
is.
I know. It's so fascinating. And like I said, my 9 years as a counselor, creative writing teacher, and then I became a science teacher, and then I became a reading teacher, and then I was everything teacher, and I was library builder. Those 9 years, that's my PhD. That's my doctorate. Really,
Oh, wow.
even my heart, you have to stretch. Yeah, I really have to stretch.
Well, I'm sure the
Really confusing because I hate
I'm,
crime.
I'm
Sorry.
sure the incarcerees appreciate your enthusiasm being there for them. So that's my last question. Someone else wants to talk.
Okay.
Daniel.
You.
So we are running a little over time. Ruben, I hope this doesn't impinge on your schedule or others who are hoping
Then.
to ask questions after. And there is another question for you, gang, but given the timing, I think we'll return to that after Ruben's remarks. So Daniel, Shay, I hope you'll be able to stay with us and ask your question at that point. So Ruben is senior expert and director of reparative justice, of the Reparative Justice Program at the International Center for Transitional Justice, where he works with victims communities and reparations policymakers in Nepal, Timor-Leste, Indonesia, the Philippines, Iraq, Palestine, Liberia, Ghana, South Africa, and Kenya. He also provides advice on issues involving reparations and war crimes tribunals in extraordinary chambers in the courts of Cambodia and the International Criminal Court. Before taking his current position at ICTJ in New York, his career in the Philippines was quite distinguished, and it included serving.
Which you need not go through, David.
Well, I'll just go through quickly that you were the commissioner in charge of litigation and investigation of pursuing the ill-gotten assets of the Ferdinand Marcos family, and concurrently served on the UN ad hoc committee that drafted the 2003 UN Convention against Corruption, along with other work. So thank you for joining us today, Ruben.
Right. I don't know if I can share a couple of slides, David, because that will probably help.
I will enable that.
Sure. Let me begin by thanking you and the organizations involved for this side event. ICTJ itself is involved in a couple of side events involving the different country programs we have. And so one of the country programs that we actually have is Colombia. And as some of you probably already know, Colombia has its own drug war, which is different from the Philippine drug war. But let me go through a couple of things. I thought I would focus on accountability for drug war human rights violations, which includes accountability for the drug war in the Philippines, but a little bit more than that. So right now we know what's going on in the United States, protests against racial injustice, protests in Europe as well against colonial injustice even. And some of those protests have included bringing down statues of Confederate generals or even the King of Belgium. So this is a statue in New York of Lin Se-tzu, and it actually just has one inscription. It just says drug war pioneer. He apparently opposed the British importation of opium into China, fought the British because of that, and was revered by the Chinese for that reason. So in a way, it's important for us to think of the longer, much longer historical context of drug wars and who's responsible for, in a way, introducing drugs to certain societies and which drug war we might be thinking about when we talk about drug wars. On the other hand, it's also important to look at accountability from a broader perspective, and that's how transitional justice comes in. It's a set of judicial and non-judicial tools for justice and accountability. Most of our work has been in post-conflict and post-authoritarian countries, and some of our work has involved addressing unresolved historical injustices, including, for instance, comfort women issues involving Japan in World War II, or even British colonialism in Kenya. So because it's both judicial and non-judicial, it's important to remember that our work and transitional justice isn't focused only on going to court. Some of the tools we use include truth commissions, and some of you are familiar with South Africa's Truth and Reconciliation Commission, but it's not even the only truth commission, nor the first one ever established. There have been dozens of truth commissions across the world, and some of them have, in fact, addressed some of the racial, equality, and even drug-specific issues in certain countries. We also work on prosecutions of individuals and civil litigation, most of them involving reparations. I direct the reparations work in ICTJ, and so reparations isn't just about payment of money. It can include symbolic forms of reparations. It can include material forms of reparations that aren't necessarily about paying money. Some examples of symbolic forms would be apology or even memorialization, which is separate in many cases because it involves a larger set of issues around remembering. Our work also includes the vetting of abusive officials, and we are involved, for instance, in police vetting in Kenya or the vetting of judges in Armenia. And then there's reconciliation, which I put in quotes because it's always tricky to talk about reconciliation. We've recently seen slogans where, no peace without justice, and no justice without no reconciliation without justice. And so I leave it as a word in quotation marks. In terms of domestic accountability, whether it's for drug wars or for abuses in general, these are some of the steps that can be taken. I won't go into each of them, but they include civil society-led truth-seeking processes. And in the Philippines, as an example, I've worked with religious leaders to examine the possibility of neighborhood truth-seeking, neighborhoods affected by the drug war, and whether there's a possibility to undertake that. That's been overtaken by the pandemic, but even before the pandemic, one problem of whether it's truth-seeking or even prosecution is always the problem of safety and the problem of fear. When a drug war is still going on, it's very, very difficult to expect the families who have been targeted by the drug war, mostly poor, which is why I used that first slide. And it's impossible to expect them to simply come forward and seek justice in the open. There's a risk to their life, and even for human rights advocates, many of them can often be co-opted and tainted. One of the prominent so-called human rights lawyers in the Philippines, for example, is now the spokesperson of Rodrigo Duterte, and he was my classmate in law school in the Philippines. You have a corrupt prosecution and court system. And the last point I think is important in relation to the drug war. There's often this unnecessary but still persistent need of finding innocent victims, that we need to look for persons who are not drug dealers, who have not been taking drugs. And that is both a dilemma and an unnecessary dilemma, because there will never be a perfect victim. You can have children, of course, and many of them in the hundreds now, or at least over 100 now, have been killed in Duterte's drug war. But in terms of persons who testify in truth commissions or in court, it will be very difficult and also counterproductive to look for innocent victims. Some of the things that are indispensable, whether we are looking for domestic accountability or international accountability, would be documentation. And in the Philippines, that has been significantly done by the Commission on Human Rights as well as non-government organizations, which is precisely why information or complaints were brought to the ICC based on documentation. It's also important to preserve evidence, including forensic evidence. And this is a problem even with documentation, because some of the autopsy reports, some of the spot reports involving drug war killings are either inaccessible to civil society groups or even to family members of those who are killed. There's witness protection, and in the Philippines, as in many other countries where you have extrajudicial killing, witness protection is often offered by the same state that carries out the killing. So it's a dilemma, and therefore privately run witness protection programs might also be necessary. So what can foreign states do to pursue accountability? Well, that's been happening at the Human Rights Council, and as some of you may have seen recently, there have been calls at the Human Rights Council to create a commission of inquiry to investigate extrajudicial killings in the Philippines drug war. There can also be pressure through trade and diplomatic means. A good example is when Sri Lanka refused to investigate war crimes at the tail end of its conflict with Tamil rebels. Many European countries actually took away preferential tariffs for Sri Lanka in order to pressure the government into agreeing to a commission of inquiry, which they agreed to and then later took back. Can foreign states ask the UN Security Council to refer a case to the ICC prosecutor? That's what happened in Libya. That's not probably going to happen in the Philippines at this point, because you have two countries that might veto any referral by the UN Security Council. You have China and potentially even the United States. But there are also countries that can directly refer the Philippine situation to the ICC prosecutor. It's possible, for instance, that at some point Iceland might want to do that. But because there is already a preliminary examination at the ICC, it's possible that the ICC will move forward with this investigation of a crime against humanity of murder. I won't go into this, but I will quickly run through some examples of transitional justice mechanisms, some of which ICTJ has been involved in, that relate to both drug wars and more broadly the right to health, which some of you have been discussing. In Mexico, there is a proposed truth commission, which up to now has not been created, but it was meant, and it is meant to examine the impact of the drug war in Mexico, including thousands of enforced disappearances. There is an accompanying proposal to offer amnesties to those who have committed crimes and human rights violations in Mexico's drug war, both on the government side and even on the side of drug cartels. In Colombia, there is a peace agreement already being enforced, and it includes provisions on the use of land that's been cultivated for drug purposes, as well as innovative penalties for the FARC, the rebel group, and some of the other armed actors that are linked to trafficking in Colombia's larger conflict. In the United States, Chicago has a reparations program and various transitional justice measures specifically addressed at police abuse, but including police abuse related to the US drug war. ICTJ has been working with the Drug Policy Alliance over the last 3 years. We started with the New York chapter of the Drug Policy Alliance, and one of the discussions involved collective reparations for neighborhoods, mostly Black neighborhoods, brown neighborhoods in New York that were targeted in the long running, in the decades of drug enforcement. And what forms of reparations are possible for them. One idea that was also discussed was the possibility of a mobile museum that would travel across New York, showcasing the impact of the drug war on Black and Brown communities. And a point about the right to health and the pandemic, because I think this is something that might be helpful. In 1918, right after New Zealand, right after the flu pandemic spread to New Zealand and killed, I think, hundreds or probably even thousands of persons, New Zealand created a pandemic commission to examine the reasons why it spread there, how many deaths happened, and ways to prevent massive deaths in the future. I'm not saying that this truth-seeking measure is the reason why New Zealand in 2020, 100 years later, has been able to effectively control the spread of the pandemic. But you have some kind of anecdotal evidence that a serious truth-seeking process involving the right to health is possible and can have consequential impacts on the way we deal with health issues, whether it's drug-related or the pandemic. So let me stop there. And perhaps there are questions around the Philippines or questions around transitional justice mechanisms involving drug wars that you want to ask, and I can answer them. Thank you.
Thank you, Ruben. And I have a pair of questions, though they're sort of theoretical. But first, let me say, anyone who would like to ask a question, make a comment. In the participants section, there's a raise hand function, and if you use that, I will call on you. Gang, I see your hand. And we have one other person in queue from before, and I think it probably a question for you, Gang. But my quick questions for Ruben. The ICC, as you referred to, has a preliminary examination underway on the Philippines, and I attended the Assembly of States Parties to the Rome Treaty last December in The Hague. That's the treaty body that oversees the ICC, and the prosecutor Bensouda said that all phases of the preliminary examination into the Philippines are in the very late stages, and there will be a decision on whether to seek authorization to do an investigation during 2020. Now the words "are very late stages" to the layperson might seem, well, it probably won't take all of 2020. On the other hand, the ICC functions on long timescales. Was wondering if you've heard anything generally, if not specific to the Philippines, on how what unfolded with the pandemic may have affected their timetable. Also, on substantive reparations, and we emailed about this, there's a bureau of the ICC called the Trust Fund for Victims, and provides support to victims. I believe this would be following, probably would be following convictions in the court. And what might victims of Duterte's drug war or other victims whose cases come up as part of a so far still hypothetical case, what kind of support might go to people in the Philippines following, if there is a prosecution and convictions in a Philippines-related case?
Well, I'll give you simplistic answers, David, to compress the time. On reparations, there is in fact a reparations law in the Philippines, and I even helped author that 15 years ago. But it's meant for victims of the Marcos dictatorship. And because you mentioned that I was involved in the recovery of assets of the Marcos family, part of those assets is what funds the reparations program for Marcos dictatorship victims. And that's important because reparations will require funding, whether it's symbolic or material. At the ICC, you're correct that the trust fund administers reparations for victims, and that reparations formally can only happen when there's a conviction. The trust fund, though, has an assistance mandate that can already be triggered when a case begins to trial, which is not where the Philippines case is right now. It's preliminary examination, as you correctly pointed out. And when the prosecutor says that they're in the last stages of that examination, you can see how complex this process is, because the stage of preliminary examination still requires a confirmation at the end of that by a chamber of the ICC saying these charges can be validly filed. And in that confirmation of charges stage, that's where the Philippines can in fact send a lawyer, and that lawyer can say, no, we're investigating on our own in the Philippines. We're trying to do our best to find accountability at the domestic level, and whether that's being done in good faith or not, that can delay any ICC trial. So we're really looking at years before an ICC trial can go forward in a expeditious way. And it's important to remember that, because in December this year, there will be a new ICC prosecutor. This new ICC prosecutor will serve for 9 years. And in relation to potential respondents in the Philippines case, you can only go to trial against people who are still alive by the time trial begins. So let's factor that in. And only a handful of people will normally be tried, not all of those policemen, for instance, who have been involved in extrajudicial killings will be sent to the ICC. So it will still be very important to have other accountability mechanisms in place, whether it's a UN Commission of Inquiry that then leads to prosecutions in the Philippines in the future, or even truth-seeking in the Philippines that can begin now, but perhaps not be carried out until Duterte is out of power. Which brings us back to the ICC itself. The ICC was asked to investigate Mexico's drug war under the former prosecutor Luis Moreno Ocampo, who rejected it, who said, no, it's a Mexican decision to proceed with that. So you have had opportunities for the ICC to exercise its powers over drug wars, over violence that comes with, you know, the excuse of suppressing drugs and dealing with trafficking, but it hasn't. So this opportunity is important because I think the ICC has to be able to show that it's not simply a court that deals with armed conflict, that it's not simply a court that deals with countries that are parties to the ICC, and China, the United States, India. These are countries that are not parties to the ICC, so they won't necessarily be brought to that court. So it's important for the ICC to consider the Duterte Philippines case as an example of broadening its mandate, of making itself relevant. So let me stop there.
I'll say one hopeful comment that Prosecutor Bensouda made was that her view is from any examination which from which the information says that statute says there should be an investigation. Her view is they should open an investigation. That's not answer the question of resources and prioritization, and the court is not that large an entity. But our next question is from Daniel Shea, probably for Gang, but he'll based on the timing, but he'll clarify. And then after that, Gang, it looked like you wanted to say something. So after you'd be next after that, and then we have a question in the chat from Andrew Tatarski. So Daniel.
Hi, everybody. Thank you very much, David. My name is Daniel Shea from A Touch of Light out of Seattle in Washington State. We've been working with incarcerated artists locally, nationally, and internationally for the last few years, which is why you really sort of caught my attention, Gang. Less of a question necessarily, more just like, hey, we would really love to connect with you. It sounds like you are doing some fantastic and amazing work. Hello to Charlie as well. since we've done a bit of work with Mr. Sullivan and Cure over the last couple of years as well. That's basically all I had. So hope we can connect. And Mr. Borden, thank you very much. Pleasure to sit in and listen to all the rest of you folks. Ruben, the discussion that you had as far as the Philippines and not only the drug war, but how that is being dealt with. We're interested in, conversing further on that. So thank you very much.
Sure, Daniel. Well, I'll find you on the internet. That's easy. What I wanted to say was to backtrack a little bit. There we had this Comprehensive Dangerous Drugs Act, isn't that right, Ruben, in 2002? And that's really when the congestion started. What happened was some of the articles, all of a sudden there was a measurement of what the grams of possession of whichever drug, whether it's ecstasy, MDMA, marijuana, which for us is still illegal, and et cetera, et cetera. I think they reduced the amount of grams to make it non-bailable, right? So let's just say from a kilo to 10 grams. That's not the actual number. And so what happened was jail started to get congested. And this is exactly why I was assigned to do a documentary on why jails are congested, because that was the problem. And at that time, the Chief Justice was Renato Puno. And one of the first things I had to do was go around the country and actually visit detention centers. So we visited our team of 4 filmmakers, and we're actually 4 friends. And then because I didn't want to do the documentary alone, it was going to be too emotionally taxing, and also I felt safer to work with 3 other male filmmakers, to be very blunt. So we went around. We actually visited 51 institutions. 38 would be detention centers, and the rest are actually provincial. And the thing I noticed is in detention centers, when they're newly arrested, the energy, the feeling inside is just a lot more tense than when they're already convicted. There's a reason, because either many of them are withdrawing from the drug, whatever, with nothing there. They're not sure. They have no representation, and etc. So part of our thesis was supposed to do, part of our research was supposed to be what causes congestion and how do we address it. And naturally, a lot of businessmen would propose building larger prisons, having it privatized, making it outsourced, change the location, because the present maximum security is in actual gentrified area, and the lot is the real estate is really jumping up. So one of the things that I focused on, my documentary was the most boring. I focused on the lack of public attorneys. So it was really the most boring. The 3 others were very graphic. They studied the gang system. It's so funny. I'm named Gang and I teach in prison. How's that for fate? So they learned the gang system, how it actually helps out with discipline and safety inside. And another one studied the food. Another one studied what's the word? The org chart, the organizational chart of the mayor and who's in charge. I did the public attorneys. Do you know that at that year, I don't know what the numbers are like now. I don't imagine it's tremendously better. But when I did my documentary, my working title was 1046-2261. You know what that is? 1,046 public attorneys in the entire Philippines. That's 7,107 islands. Okay? And 2,261 courts. Okay? 25% of which, or 23%, don't have judges. And I was like, how do we? So there are judges rotating, and there are people charged with nothing, with no days in court, because judges in a conference and judges in the other court. And not only that, I've met real people, real inmates, 4 years, no arraignment. He doesn't even know what he's charged with. No lawyer. He's not sure. And then there's 17 years. He served 17 years. Every 6 months, he goes to court, and judge is not there, so he has to go back. And since it's a round robin and there's no judge in another court, he has to go back. And then he found out, finally, he's convicted of the crime, and his sentence was only 4 years because he only stole wire from our electric company, Meralco Manila Electric Company. And so the state kind of owes him 13 years. So I was we always have this running joke like, why don't you go ahead and steal furniture because you already served time for it. But that's just a joke. But the next is, I think the reason why I'm sharing this is because the reason why a lot of our courts are empty, meaning there are no judges, is because very few want to be appointed. Because look at just recently, is that right, Ruben? We've had what, 3 or 4 deaths of regional trial court judges. Investigations go nowhere, brick walls, etc. And a lot of the judges are not safe physically, so that nobody really says yes. And if they are, they tend to play safe and etc. I'm not saying everyone. Certainly, there are very brave and very courageous judges around, and normally they're the ones who are very franchised. So they're either from a wealthy family, a very powerful family themselves, but certainly not the career judge. And I'm just so stunned to find out that Ruben actually went to law school with Duterte, because I always wondered about that. So I guess I wanted to share that backtrack. That's where the drug war is connected. Even the drug war is connected to the congestion. And of course, it doesn't even count the street killings in the street. And that to this day, there is not one big drug lord in jail, except they said, allegedly, Senator Laila de Lima, who is in jail, can't bail for a drug charge when they never found any judge in her person, in her domicile, nothing. But she's still in jail, and it's been 3-some years. So that's what's happening here. I'm sure you know that. I think I just wanted to say it because I just wanted other people to listen, and maybe you can do something where you are. Maybe there's a human face to it because it's real.
And Senator de Lima, in fact, was subjected to a largely incommunicado situation for
over the pandemic. Yes.
Yeah, partially lifted, but they took the opportunity to bar her from speaking with anyone except for the staff at the Camp Crame detention center. And
yeah.
Recently that she's been able to have contact with family advisors, etc.
I also need to synthesize this for those who are not quite familiar. Senator de Lima was imprisoned, charged without bail, in the first 6 months of her term as a senator, the first 6 months of his term as president. Can you imagine how that made our legislators feel? And now you know why our legislators always swing his way, because in the first 6 months, he did a demo. This is what I can do. Non-bailable drug charge. It's insane. But here we are.
Yes. So we had a question from Andrew Tatarsky. Shall I read your comment, Andrew, or did you want to join?
I did read it, David, so I can directly answer it.
Yeah, that would be great. I mean, the main point that I am concerned about, I'm a treatment person. I've been in the field for many years, and I've been very concerned that most treatment globally is inadequate at best and frequently damaging at most. And that's particularly so in, and I kind of see the inadequacy of treatment as being a byproduct of prohibition and the drug war. And so I think that the inadequacies and the damage done in the name of helping often is given short shrift in the drug policy world, and that really needs to be one of the pillars of drug policy reform. Particularly when there's mandatory treatment, like in the Philippines, but even in the United States, we call treatment voluntary. But under prohibition, when people are given the option of treatment, it's sort of like mandatory treatment. And I think that mandatory inadequate treatment is often, just as traumatic as prison, and that is a major issue that we need to address as a global community. So I'm curious about your thoughts about how we might take that on.
I'm sure our colleagues from the UN have larger policy answers. So I'll just make 2 points. Reparations for instance, torture victims includes rehabilitation programs. And that's been one of the pillars of reparations design that people like me and others have worked on. There are even programs in Chile, for example, a separate healthcare system was established just for victims of the Pinochet dictatorship and their healthcare needs. So you have reparations that can directly address the health impact of torture, of other physical integrity violations. And I don't see why rehabilitation as a form of reparation shouldn't apply to victims of the drug war or victims of enforced and cruel and unusual punishment that might include, detention in effect, or unjust terms of rehabilitation. One important point to consider, particularly in the Philippines, but even elsewhere, is also the class differentiation in terms of rehabilitation. There's access for privileged and luxurious rehabilitation in the United States, in the Philippines, elsewhere, but public rehabilitation is something as cruel as punishment itself. So that's one. The other aspect, perhaps, that's important to consider here is that these are social rights. These are protected as much as civil rights, as much as political rights. And there is, in fact, a mechanism in the UN Convention on Economic and Social Rights that now allows for complaints to be filed before a committee that enforces that convention. It's in effect, many countries are still not parties to it, but I hope that our colleagues in the UN can take on the role of convincing countries that in their drug policy, access to rehabilitation that is humane should be considered a social right, and violation of that social right should be subject to a complaint mechanism in this convention. But because our focus is often on violence in terms of physical integrity, killing and arrest, it's often neglected. And so I think it's something that ought to be considered.
Thank you.
I think it's hard to ignore even the mental health aspect, because as a teacher, I can say almost every single inmate I've encountered has an unprocessed childhood trauma. I can easily say at least 98%, which makes it preventable, apparently, which makes crime a preventable thing, it turns out. And I think we need to start that now, like with this next generation. I was going to say next generation of criminals, but that doesn't sound right. But with the next generation, we're going to have to start it from there. And so we can't help but have multi and cross-disciplinary approaches to these issues and to these challenges. We really can't deal with it as mere rehab in the physiological sense, because there is always the other aspect, really, which is, parenting, community, etc. I was going to say, I shit you not. Is that okay to say? I kid you not. Every single inmate I encountered will have one story of an unprocessed trauma, whether it's excessive neglect, sexual abuse, physical abuse, or emotional abuse, or verbal, or all, or everything. And these are just reactions, and some are really just disorders caused by trauma that festered and became large, and then it became a life of crime, and then I asked them, there's one last story. I met an inmate who was already set free. He did his time, and he applied as a cook in the kitchen of the prison. And I said, don't you want to leave? Don't you want to go home? And he said, all my life I've been in the street. When I was incarcerated, it's the first time I had a schedule. I knew what to do at 9 a.m. I knew they counted us at 12, and I knew at 5 o'clock they'll close the gates. I felt kind of safe at night. And in the morning, I knew exactly what to do again, and there was certainly a meal. And for the first time in my life, I felt there was order. And so I don't want to leave. Outside is too scary for me. That's not even institutionalized in the way we understand it. This is someone who found a parent. Can you imagine? So I really think many multidimensional sectors should really cooperate in this, from law enforcement to drug rehabilitation to reparation, what Ruben's expertise, everybody else's expertise, and then now we have COVID. You know, it's really so. But we have our work cut out for us, I suppose. This is why I'm very grateful. I was part of this tonight or early morning, because I would like to see if there's other things some of us can work on together. Like Ruben, I'm so curious about learning more from you. Dr. Salah as well, Nainan, of course, Charlie, and David, thanks for coordinating this, and Andrew also. I need to learn more about the treatment aspect. I really appreciate it. Thank you. You give me hope.
Ruben's informed me he has to sign up for a meeting. Thank you for joining us, staying so long over time. For our speakers who remain, I wish I thought of asking this before, but you probably know the expression elevator pitch. And we're trying not to ride elevators right now because of the pandemic, but if one had the opportunity to do an elevator pitch to a legislator or a governmental leader, what are your most important asks we should give for what to do right now? What the UN and its member states should do right now to give their best for the areas of the Sustainable Development Goals that you are most focused on. Ehab.
Thank you very much. Can I say something? And I had to raise my hand manually because I couldn't find this button for raise hand thing. Earlier, after my presentation, there was a question, and I promised to get back to you on it, which is related to the prevalence of HIV in the prisons in the US. So I managed to get the data. Let me start with saying that HIV, or the epidemiological situation of HIV in prison, is reflecting the community. And this is clear that in countries where there is a generalized epidemic of HIV in the community, you will see higher prevalence in prisons as well. And a good example is Eastern and Southern African countries, where you can see the prevalence in prison can reach up to 15% against the global prison prevalence, which is 4.6%, as I mentioned. The data I'm talking about right now, and that's there's a study that has been published in The Lancet. It's available online. And the name of this study, or the title, is The Global Burden of HIV/TB in Prison Settings, which has been released in the Lancet in 2016. And it's indicating that the HIV prevalence in North America is below 2%. This means that it's lower than the global average, while HCV is close to 15%, which is very close to the global average of HCV prevalence in prison, and which is 15.1%, as I mentioned earlier in my presentation. Thank you.
Thank you. Any thought, any additional contributions from our speakers, be it elevator pitch or otherwise?
Yeah, thanks, David. If you'll allow me, it's just that COVID-19 is colliding with ongoing HIV epidemics, and this crisis wake-up call to do things differently. And we need to always remember to keep communities and people in the center of everything we do, and have a public health and a human rights approach to the work that we do. And that is what UNAIDS is committed to doing, and we will continue to do with all our interactions with all our stakeholders. Thank you.
Well,
I want to thank Andrew for the comment, because I think the sentences or the phrases I was looking for earlier was to shift the understanding or the view of drug use and etc. from a terribly harsh glare of criminal light in the criminal light and shift it, not shift, 'cause, that's a byproduct of it, but it's really a cross-disciplinary thing. There has to be other approaches to it, really, and biopsychosocial most definitely. It's not as simple as, oh, you're using drugs, we'll lock you up, but you should separate you from the people you can harm, from the collective you can harm. Now stay here. No, and that's usually how we solve it. It's really, but actually, if you dig through it, and if you've even barely read a sentence from Gabor Mate, you know that addiction and everything is really a response to try to soothe certain things. And addiction is actually not the problem, but an attempt at a solution to escape larger, deeper, sharper pains that are never processed. And I'm talking about the larger majority of drug users. There are some that are really might be on a different range, sui generis altogether, but majority has to be approached on a biopsychosocial manner, really, and not neglecting the mental health aspect of it. I've seen it. 98% easily. I can go 100. I can bet. I can, okay, $1. No, okay, $10. I can bet $10, 100% unprocessed trauma somewhere. And then they end up there. We can't just change our practice. Yeah, but at least we must try. Or at least incorporate. We can't change the police part of it, especially in my macho government. We really can't change the police SWAT part of it. That's there, and perhaps it's necessary. But there should be other strains to the braid. There has to be other approaches. They should be thrown to more appropriate places.
Well, this is Michelangelo from Delaware. I think unprocessed trauma is something to think about. That term is very deep. Unprocessed trauma. I know what you're saying. It's very, very deep. Thank you for bringing that up.
Most welcome. Please think about it and then do something where you are. And if you can help us over here too, that would be awesome.
Any more questions or comments?
Yeah, David, I just want to emphasize what I said in my note, that I think that generally, there tends to be a focus on shifting our practices, but that if the dominant practices are based on wrong ideas about how to understand problematic drug use or drug use in general, that are based on these old ideas of drug use as immoral, which then sets the stage for criminal, which then sets the stage for punishment and stigma, that we really need to focus on changing the narratives and kind of helping people adopt a whole new way of thinking about these issues, which then is kind of it offers a different lens through which to understand why people engage in problematic use, that then will support the shift in policy and treatment that we're all, working toward.
Thank you, Andrew. I'm learning so much from everyone.
Yeah.
It was worth staying up. Okay.
Well, I'm glad that you feel that way. I've certainly gotten a lot from this as well, and I want to express my appreciation to all the speakers and to all of our attendees, but especially those of you who stuck it out through what turned out to be more than a 2-hour forum. One of the silver linings of the current situation is that we have not caused another NGO in the same room to have less time for their own setup of preparations for their events. The UN Sustainable Development Goals, for those of you not already familiar, are worth reading up on and getting involved in. My my new phone actually came with a Sustainable Development Goals app pre-installed. And so they have a wide following. I'm not remembering the exact URL, but you Google Sustainable Development Goals, you'll get websites from the UN Foundation, and lots of other information. Our own work on international programs, you can read about at stopthedrugwar.org/global and stopthedrugwar.org/Philippines. And we are involved in domestic policy as well. If you're not already a subscriber to our newsletter, hope you'll visit our website and sign up or send me an email. I'll be glad to sign you up. And I'll leave the chat on for a couple more minutes in case anyone wants to scroll through the group chat, see some of the interesting comments on it and resources people have linked. But at this point, I'd say we are adjourned. And so thank you all once again, and good luck to everyone wherever you are.